Bunte is here from Mahi, from Mid-America Heart, and I'll get his presentation started, and appreciate you coming.
Thanks, Skylar. Well, I'm pleased to be here, really honored to be here, frankly, and thank the steering committee for asking me to talk to you today about the right antiplatelet therapy, specifically for folks with critical limb ischemia. And it's a little tough because there isn't a lot of data on our critical limb ischemics, but I think there's a lot of themes, and to get to Dr. Jones's points about trying to target and pin down which population of patients these antiplatelet medications help. I have no disclosures. Nationwide, the admission rates for CLI have been stable over the last several years here, yet in 2003 the inpatient mortality rate was 5.4%, and in 2011 it certainly decreased to 3.4%, but I'll remind you that that is near the same inpatient mortality rate for acute MI and acute heart failure. So the role of an antiplatelet in critical limb ischemics should do three things. It should reduce cardiovascular event risk, first and foremost, and improve survival. It should hopefully reduce adverse limb events and also improve symptoms. And we've presented a lot of historical data today, and this goes even farther back, Dr. Creaky's seminal paper in 1992 in New England Journal, showing that the more symptomatic and severe the peripheral artery disease, the worse the outcomes over a very long follow-up. So we're going to focus today on kind of three separate pathways that are associated with platelet aggregation. We'll talk about the thromboxane pathway as well as the P2Y12 antagonist we're all familiar with, and I'm just going to touch a little bit on the PAR1 antagonist for Paxar that's been studied. These are the 2016 guideline recommendations, and this is just the level 1 recommendation that Dr. Jones just showed you. And to give you some context about this aspirin dose, 75 to 325 and Clopidogrel once a day, I just wanted to go back to the Antithrombotic Trialist Collaborative to where this data originates, and they showed in that meta-analysis that the aspirin reduced the odds by 18 to 22% if you included Capri in that analysis to reduce events including vascular death, MI, and CVA. And most of the risk reduction was in that 75 to 325 group. So Clopidogrel versus aspirin in reducing cardiovascular event risk, we were also noted the aspirin to be a fairly modest effect. There was some benefit to other antiplatelet therapy, including dipyridamole and ticlopidine in the ATC meta-analysis. But Capri really was the foundational study of the benefits of antiplatelet therapy in PAD, and studying a dose of 325 of aspirin versus Plavix. Three subgroups. Symptomatic PAD comprised about a third of that population, and an impressive 23.8% relative risk reduction. And Dr. Jones just showed you that forest plot with the hazard ratios. If it were not for this PAD subgroup included in Capri, that would have been a negative study. There was no benefit to folks with MI and stroke, and that really was interesting and prompted a lot of other interest in this area. So we really need to balance clinical events with risks of bleeding. There's possible additive benefits to higher risk populations, and I'm hopefully going to convince you that. Unfortunately, Charisma didn't get us to that answer. We studied aspirin versus aspirin plus Plavix, mean follow-up of 28 months. No benefit to overall risk. Keep in mind that 21% of the population enrolled in Charisma were by risk factors alone. Folks had significant benefit if they had significant atherosclerotic disease. Although unique to Capri, Charisma did not have any benefit to symptomatic PAD. So I'm not going to go through Euclid a whole lot because Dr. Jones has done a good job with that, only to say that 4.6% of the study population had rest pain or tissue loss. So this is a fairly standard ambulatory PAD population, and again, no benefit there. Dr. Jones did a sub-analysis of Euclid looking at the folks who had had prior revascularization, trying to hone in on perhaps there was some benefit to a more symptomatic cohort, but unfortunately that didn't pan out either. There was, compared to patients enrolled by ABI criteria alone, those who had revascularization were a higher proportion of patients already taking aspirin, Clopidogrel, statins, and 15% took cilostazol. There were certainly higher rates in that symptomatic population of both MI and acute limb ischemia, but no difference in the primary efficacy endpoint. So along comes Vorapaxar. It's a novel strategy to treat and reduce risk in these patients. It is a thrombin-mediated mechanism that was studied in the 2P TIMI-50 study. And again, I'm not going to go through this in great detail, but only to suggest that of the nearly 27,000 people enrolled, 3,800 were enrolled with peripheral artery disease. And after 2 years, the DSMB discontinued the study in patients with a history of stroke due to increased risk of intracranial hemorrhage. There was an impressive reduction, however, overall, 11% relative risk reduction in the primary efficacy endpoint for the overall population, but that was really balanced with the hazard of bleeding. Gusto, moderate, severe bleeding was significantly increased during the follow-up. Looking at Dr. Banaka's work on the PAD population specifically, there certainly was a reduction in acute limb events as well as hospitalization for peripheral revascularization, but again balanced by that risk of bleeding. This is a work by Dr. Armstrong basically getting more to our point of this talk about CV risk reduction in high-risk population. Very nice study, propensity-matched retrospective analysis of 629 patients with symptomatic PAD. Important to note that 58% of these folks had critical limb ischemia, and they were evaluated for outcomes based on their antiplatelet regimen. You can see the breakdown of Rutherford class there. 55% were prescribed aspirin and Plavix, whereas 45% had aspirin monotherapy. MACE event rates, as you might imagine, in a critical limb ischemic population at 3 years were much higher with compared to the other studies we've looked at. Aspirin and Plavix, however, had a lower event rate than aspirin monotherapy. And compared to aspirin monotherapy, there seemed to be a significant benefit to dual antiplatelet therapy with regard to MACE, but not MALE. And here's kind of the graphs or plots that show that, where A is the MACE, and you can see there's a significant benefit of dual antiplatelet therapy in red. Death is in B. C is major amputation or death. There was no difference in MALE, which was shown in slot D there. Another study looking at a dual antiplatelet therapy and improved late survival after revascularization for CLI in a U.S. population. Whether you were treated with bypass or endovascular means, if you got dual antiplatelet therapy after your revascularization, you had better outcomes than aspirin alone. So talking about limb-related events and thrombotic risk, particularly for this critical limb ischemic population, is important. Compared to placebo, there has been a signal of evidence for reduced incidence of arterial occlusion, but there's probably more to the story. Aspirin is just as effective as warfarin on infrainguinal arterial graft patency, which is why we don't use warfarin to keep grafts open these days. And the CASPER trial was a great study of 2/3 of the population being CLI, by the way. No overall benefit to aspirin plus Plavix versus aspirin alone on adverse limb events among patients who required below-knee bypass. So more of a surgical population, but again, aspirin kind of holding its own. Charisma had a reduced rate of hospitalization for ischemic events with DAPT over aspirin. Vorapaxar was associated with the reduction in acute limb ischemia, as we've seen. And there's an increased hazard of stent thrombosis when no antiplatelet agent was used in a contemporary drug-eluting stent for the SFA disease in the Zephyr registry. There was a rate of stent thrombosis of 2% with the Zilver PTX stent in that registry. So clopidogrel and limb events were also studied in this large population of Medicare patients, and basically all these patients had endovascular revascularization for symptomatic PAD. Importantly, 60% had CLI. Results included about 38% given clopidogrel after endovascular revascularization. That's, to your point, Dr. Jones, that a lot of these folks probably aren't getting clopidogrel. Clopidogrel also was associated with reduced 15% risk of amputation at a year, and the greatest benefit was seen in those with tissue loss. Cilostazol is not to be forgotten, a very important medication that I frankly think is underutilized and understudied. It's a phosphodiesterase inhibitor. It has platelet activity as well as a function as a vasodilator. Helps to downregulate inflammatory markers in some studies and may have durable benefits against limb events. And this is just an example of that data. Cilostazol associated with reduced amputation rates regardless of revascularization strategy in bypass or endo patients. People who got cilostazol prior to their procedure for CLI had much lower event rates long term. So this is kind of a summary of where we've been over the last 20-some years. where from the Antiplatelet Trialist Collaborative, the estimated event rate for placebo in that population was about 6%. In Capri, we had that dramatic reduction with Clopidogrel, and Euclid unfortunately didn't pan out for us. But keep in mind that 4.6 of the population of those nearly 14,000 patients were CLI. When we look at Charisma, again, there's not a lot of benefit to aspirin and Plavix alone in a general PAD population, but if you look at Armstrong's data, where 58% of the patients that had critical limb ischemia, event rates are much higher, but so is the benefit to these patients. So in conclusion, data derived from observational studies and post-hoc subgroup analysis of PAD provides some but pretty limited data on CLI. Post-procedure DAPT over aspirin alone likely reduces the risk for those with CLI, although definitely requires additional study. And cilostazol may prevent CLI limb-related adverse events. Substantial opportunity to improve outcomes for these patients, for sure, with critical limb ischemia, I think is one of the important directions we need to take this field. And that's the end of my talk. Thanks for your attention.